All right, next paper is intraoperative infusion of dextran confers no additional benefit after carotid endarterectomy and is associated with increased major adverse events. Presented by Dr. Moore. Authors are from New York Medical College, NYU, and Westchester Medical Center.
Hi, my name is Jessica Moore. I'm a second-year medical student from New York Medical College. I would just like to thank the program for allowing me to present our work. We looked into the intraoperative infusion of dextran and confers no additional benefit after carotid endarterectomy, but is associated with increased major adverse cardiac events. There are no disclosures to report. Dextran is a plasma volume expander. It was originally introduced in the setting of trauma. It also has antiplatelet effects, which led to its use in vascular surgery. Previous studies have found that transcranial Doppler monitoring in association with dextran infusion actually lowered microemboli signals using transcranial Doppler monitoring. And these studies found that dextran actually reduced the risk of arterial thromboembolism during carotid endarterectomy. However, there are adverse reactions that are associated with dextran use, including anaphylaxis, hemorrhage, MI, and stroke. Therefore, given the benefits and risks of dextran that we know, we decided to compare the postoperative outcomes of carotid endarterectomy stratified by the intraoperative infusion of dextran. This is a retrospective analysis from 2008 to 2022 from the Society for Vascular Surgery Vascular Quality Initiative database. We included consecutive patients 18 years and older undergoing carotid endarterectomy. We excluded patients undergoing simultaneous coronary artery bypass graft, endovascular intervention, and lower extremity bypass. We also excluded patients on hemodialysis with a history of ipsilateral carotid endarterectomy, prior neck surgery, prior radiation, and we excluded cases missing intraoperative dextran use. We stratified the groups by the use of dextran. We collected demographic, comorbidity, medical history, procedural information, and in-hospital outcomes. Primary in-hospital outcomes included stroke, death, and myocardial infarction. Secondary outcomes included in-hospital major adverse cardiac events defined as myocardial infarction, congestive heart failure, and dysrhythmia. Stroke, death, myocardial infarction, congestive heart failure, dysrhythmia, reperfusion syndrome, hemodynamic instability, and major bleeding. First, we found that patients receiving dextran infusion were more likely to be Caucasian than other ethnicities. Patients receiving dextran infusion were also more likely to have ipsilateral stenosis greater than 80%. They were less likely to be symptomatic, and they were less likely to be on preoperative medications, including antiplatelet therapy, anticoagulants, and statins. Procedurally, first we found that dextran infusion was associated with increased use of general anesthesia, increased use of patch, shunt, and drain. Regarding in-hospital outcomes, we found that dextran infusion was associated with a significantly increased incidence of myocardial infarction, acute heart failure, dysrhythmia, and hemodynamic instability. Unlike previous studies, we did not find that it was associated with a decreased risk of stroke or death. On multivariable analysis, when we adjusted for baseline differences between our groups and confounding variables, we found that dextran infusion was associated with a significantly increased risk of congestive heart failure, myocardial infarction, and hemodynamic instability. There was no decreased incidence or risk associated with stroke. Therefore, we conclude that intraoperative dextran infusion was associated with an increased risk of major cardiac events, including myocardial infarction and congestive heart failure. However, it does not decrease the risk of stroke or death. In conclusion, we suggest the judicious use of dextran in patients undergoing carotid endarterectomy. Furthermore, we suggest careful perioperative cardiac management is warranted in these patients. Thank you, and I welcome any questions.
Dr. McKenzie?
Yeah, Jim McKenzie, New York.
kind of an interesting concept, but I have to look back in my retrospective scope, and I used dextran probably half a dozen times in 30 years of practice. What was the incidence of actually using dextran in the VQI relative to the entire database? And the times that I tended to use it was if I saw some type of platelet aggregate or something I didn't think, or saw clot forming. So when are you at NYU or through your consultants and your co-authors there using dextran, and when was it used in VQI?
Thank you for your question. That's a great question. So this was a pretty large study. There's about 140,000 patients included in the study, and there was only 9% of those patients received dextran infusion. We actually also found that there was a trend towards a decreased use of dextran, and that seems to be consistent with other studies. We weren't able to look at certain operative factors, such as when surgeons were selecting to use dextran, given the fact that it was a retrospective analysis and a registry study. But I think that that would be a really interesting point to look into, knowing that there has been a decline in the use of dextran over time, given the risks that we know and more information that's coming out. But unfortunately, we don't have that information at this time. Thank you. Right. Thank you for your comment.
So to try to answer Dr. McKenzie's question, it's 15 years since I graduated at NYU, and I'm at Western Medical Center. We used dextran once in the case of TCAR that had postoperative stroke within 60 minutes of bringing the patient to the recovery. And I think, because we looked at it, I think what prompted us to use it is that despite the patient being on dual antiplatelets, we were not sure how effective Plavix activity was in this patient. And that's why we introduced dextran. So that actually led to the change in practice where we not only put patients on DAPT, but we also look for levels of activity for Plavix in these patients prior to going to the TCAR procedures. So that's, but I'm completely seconding your, vast, broader experience than mine. And although it's a board question on vascular boards, what do you do when you find a carotid endarterectomy stroking out and you go back and you find white clot? You give them dextran. I've used it once, and that was the circumstance. So,
Thank you, Dr. Skowski.
Dr. DiMartino.
Hi, Randy DiMartino, Rochester, Minnesota. I enjoyed that. Thank you. I'm curious, one of the nice things about VQI is you can at least try to cluster your cases by surgeon or center. Part of me wonders if there's some sort of, somebody that's just their practice, or maybe a group and that's their practice and they do it a lot, because as I think a lot of folks probably just don't use it. So did you find that these cases of dextran use were clustered amongst surgeons or centers, and then did you then use that in terms of your modeling, in terms of your outcomes? Thank you very much.
Thank you for your question. That is not something that we captured, and I think would be really interesting to look at given the large amount of centers that participate in VQI studies and the different types of centers. I think, operative decision-making plays a role here, and that's something that we could definitely look into in the future. So thank you.
Good job.
Thanks.
Thanks.
Thanks.